السلام عليكم ورحمة الله وبركاته. معك مرة أخرى دكتور ياسر طاقة. And today I'm going to talk to you in my third lecture. I'm going to talk to you about two important subjects which are of basic neurosurgical problems. In fact, these two subjects are correlated with each other, so that for this reason, I'm going to speak about them, both of them, in this same lecture. To start with, these subjects are hydrocephalus, number one, and number two, the other subject related with it or correlated with this is the spina bifida or neural tube defect, and then you also know all the important details regarding these two subjects. To start with hydrocephalus from its name in this Latin words, hydro means water, and cephalus relate or meaning to the head. The same term used in our language, general population, they are saying, I think all of you had heard one day that they got a baby having water in the head. أكيد سامعين المصطلح، يقول والله جاء طفل عنده ماء براسه. هذا المصطلح هو اللي إذا سامعين به هو هذا المقصود به الهيدروسيفالس. لاحظوا أن المصطلح اللاتيني يستخدم نفس الكلمات، نفس التعبير أيضا. hydro means water and cephalus head. So that there's water in the head. From where this water is coming? In fact, I'll show you this CT scan of the brain. In this side, this is normal CT scan of the brain. I think you saw this picture before when I spoke about the first lecture about neurosurgical investigations. Now, if you can compare between this one and this other one on the right side, what are you going to see? There is difference between the two images with regard to the brain tissue, also with regard to more prominent the ventricular size, the size of both lateral ventricles. You can see, frankly, there is a frank and gross dilatation of both lateral ventricles, the right and the left one. Also, you can see that these are normal gyri and sulci of the brain, all disappeared at here because they are all compressed. In the radiology, they term this as effacement of sulci and gyri, or disappearance of sulci and gyri due to edematous brain, due to this strong pressure from the dilated ventricle on all sides of the brain. And also, we will return back to the same term when I was saying to you that this cell is a closed box, and so that the brain tissue will be carcerated between these two limits, between the pressure of water and the pressure of the skull bone. So this edematous brain. From this image, you can know the danger of this disease, I mean hydrocephalus. In fact, yes, it is called hydrocephalus, but it's a generalized disease and caused by many other diseases. Now, by definition, hydrocephalus defined as abnormal accumulation of cerebrospinal fluid (CSF) within the ventricles and subarachnoid space. It's often associated with dilatation of the ventricular system and increase in intracranial pressure. You know what I mean by increased intracranial pressure now very well, because I told the details of this subject in the last lecture. Now, regarding physiology and circulation of the CSF, the normal amount or normal value of circulating CSF at adult person is about 150 mil. The daily production of CSF is about 450 mil. So that the CSF is replaced approximately 3 times a day. You know that the total amount produced every day is 450 divided by 150 present at any time equal 3. So at 3 times the CSF is changed. CSF is produced by active process independent of intracranial pressure, and this I must interpret to you to know what I mean by this sentence. No, you must know the following: that CSF production is active process independent on the intracranial pressure. You know, we have what's called the heart circulation, blood circulation. Here we will have what's called CSF circulation. Now, pumping of blood from the heart is correlated with the blood pressure, what's called the blood pressure, and this blood pressure varies from time to time. Now, if a patient got hypovolemic shock, for example, injury to the big vessel, and got hypovolemic shock, hypotension, what the compensatory mechanism will be? There will be tachycardia. Oppositely, if a patient is having hypertension, he will get bradycardia. while here, so that this is compensatory mechanism, but the production of CSF is independent of the intracranial pressure. I mean, even if it is increased, I mean the intracranial pressure, for example, by specific migration. For example, I repeat the sentence again. The skull is a closed box containing three things. Number one, the brain tissue. Number two, the blood in the vessels. And number three, the CSF. Now, if there's increase in the amount of the size of the brain, for example, by brain tumor. Now there will be burden on the other structures, I mean the blood and CSF. CSF production is independent of intracranial pressure. I mean, even if it increases, it will still by 450 ml per day. Although that nowadays there are some studies they said maybe decreased after brain tumor, but the well-known is the active process, independent of intracranial pressure, so that it will be at this stage to be harmful to the brain because the burden will be put on the blood and the blood will be pushed outside the brain, or the brain will be pushed out, the blood will be outside the skull, or the brain will be pushed outside the skull. If the brain pushed outside the skull, there will be herniation, and you know the fate of herniation, which I mentioned in the last lecture. Or there will be pushing of blood outside the skull, and this will lead to hypoxia of the brain. Now, 80% of CSF produced by the choroid plexus, which are located in the wall of the lateral ventricles. They are producing 80% of the CSF, but the rest of are from the brain parenchyma or the spinal cord parenchyma. Uh, after a while, I mentioned to you the CSF circulation and in the interruption in the flow of CSF within the pathway, this will result in accumulation of CSF above that level. Now, if there's obstructing agent, for example, in the cerebellum, I mean posterior fossa tumor, there will be complete occlusion of the fourth ventricle. The other ventricles will be all dilated. Now, if I do lumbar puncture for this patient, it's contraindicated. But if I imagine that I did lumbar puncture for this patient, I will get CSF. Now, this is accumulated CSF below the level of the obstruction. Now, if I will be waiting, will I get CSF or not? Yes, I will get CSF. So, from where the source of the CSF is from the, if it's a blocked the CSF pathway, it is from the parenchyma of the brain or of the spinal cord. What are the functions of the CSF, of cerebrospinal fluid? The number one is to protect and support the brain and spinal cord. This is very quite important, how it will protect and support the brain and spinal cord. As I mentioned, for the third time I said the skull is a closed box. This box from the anatomy. From outside is smooth, but from inside not so smooth. There are some ridges, for example, the sphenoid ridge or other ridges. You know this very well. Now, any hit of the head by, for example, by sharp object, for example, by a wall or by a car, there will be concussion. The brain will be hit by the wall of the skull from inside, and there will be injury to the brain tissue by this hit of a brain to the inside of the skull with its protrusions. Now, the CSF will act as a protective. How? It will lead to floating of the brain. Floating of the brain. يعني نرجع إلى تذكرون لغاية الأجسام الطافية لأرخميدس أنه the brain will be floating so that the normal weight of a brain, which is about 1 kilogram plus 100 gram, it will be just like 100 gram. So it will be light and will be floating and be protected from concussions. Now, the other function of CSF, maintenance of hemostasis by acting as transport medium for transmitters, and as method of removing the end products of metabolism. In fact, CSF will act as lymphatics of the brain, because you know that the central nervous system have no lymphatics. The cerebrospinal fluid will act as method for lymphatic. Instead of lymphatics, the CSF will act by the mechanism to take removing end products of metabolism. Regarding CSF circulation, as I mentioned to you that at the start, that the CSF is formed from the choroid plexus located in the wall of the lateral ventricles and from also the parenchyma. Now, the main source 80% from the lateral ventricle, I mean from the choroid plexus. This will put the CSF inside the lateral ventricle. From the lateral ventricle, the CSF will pass to the third ventricle via what's called foramen of Moro, or called interventricular foramen. From the third, it will pass from the lateral ventricle to the third ventricle. To start with, we have two lateral ventricles. In how the ventricular system of the brain consists of four ventricles. They are at different levels. The higher level are two ventricles, the right and left lateral ventricles. They are not named as first or second, because if you say the right is the first, why the right is the first, not the left is the first, or the opposite? So that they are called as the right lateral ventricle and left lateral ventricle. Then we have single third ventricle located in the midline. And lastly, we have single fourth ventricle midline. And the highest level is for lateral ventricles. Then lower down, you will get into the third ventricle. And lastly, you will get inside the fourth ventricle, low lying between the cerebellum and the brainstem. Now, from the lateral ventricle, CSF will pass through the foramen of Moro to the third ventricle. From the third ventricle, CSF will pass to the fourth ventricle through what's called aqueduct of Sylvius or Sylvian aqueduct, a small canal. Then from the fourth ventricle, CSF will pass through three foramina, two foramina of Luschka in the lateral side. In order not to forget their name, remember that L Luschka for lateral, and foramen of Magendie, M Magendie for midline canal, called foramen of Magendie. These three channels or foramina will take the CSF from the fourth ventricle to the subarachnoid space surrounding the brain and the spinal cord, and then it will be taken, the CSF, by the arachnoid villi, which are the absorption site for CSF, to take it back to the venous blood and the bloodstream. Okay, this is what we call as the CSF circulation. To compare it with the blood circulation will start from the, for example, left ventricle, and then the blood will be back to the left ventricle of the heart. While here, the CSF will start formation from coronary plexus in the ventricle, and it will end on the bloodstream, not return back to the ventricle. In this diagram, I can show to you the diagrammatic representation of the lateral ventricle. This is, for example, right or left, and this is the foramen of Moro to pass to the third ventricle. Then this cerebral aqueduct. This is the fourth ventricle. CSF will pass into foramen of Luschka laterally, or foramen of Magendie, surrounding the brain and the spinal cord in the subarachnoid space, and then it will be back to the bloodstream through what is called the arterial flight. This is the flow of CSF also surrounding the brain and the spinal cord, third and fourth ventricle. And lastly, I show these are what is called arachnoid granulations. They will take the CSF from subarachnoid space inside the venous sinus. Look, this is in fact a cross section across the superior sagittal sinus, coronary section. In this sinus, you get the triangular cross section of it, and these arachnoid villi will take CSF to the inside of this sinus, the venous blood, and go to the bloodstream. When we say hydrocephalus, in fact, we have many classifications for hydrocephalus. One of these classifications is according to the pathological process happened, or according to clinical state of the patient. But first of all, we are classifying them according to what's called a radiological classification. Depending on radiology, you must have a CT scan or MRI for a patient to say what is the type of this hydrocephalus. According to this classification, we are classifying hydrocephalus into two types: either non-communicating, or called obstructive hydrocephalus, or communicating hydrocephalus. Why or how we classify them? Obstructive hydrocephalus, in fact, result from lesions that obstruct the CSF pathway from the lateral ventricle down to the fourth ventricle only. Okay, I return back to this diagram. Look, any obstruction of the CSF pathway at any side down to the fourth ventricle at here. Okay, this will result in what is called obstructive hydrocephalus. While in communicating hydrocephalus refers to circumstances in which the intracerebral CSF pathways are patent, but there is accumulation of CSF, usually due to impaired CSF absorption. Where is the absorption? At the absorption site, arachnoid villi. These arachnoid villi. If there is no absorption of CSF will be accumulated, but there is no obstruction of the CSF pathway. Now, Regarding epidemiology of hydrocephalus, the incidence of infantile hydrocephalus is 3 to 4 per 1,000 birth of life. What are the etiologies of hydrocephalus? In patients with hydrocephalus, an imbalance has occurred between the normal physiological production of CSF and its absorption. This imbalance can be as a result of either overproduction of CSF, overproduction, for example, a tumor in the forming site, I mean the site which is formation of CSF, which are the arcuate villi, or obstruction of the flow of CSF, or impaired absorption at the absorption site, which are uh, the arcuate villi. Now, you can see this image is post-mortem specimen of normal person coronary view, lateral ventricle and third ventricle, which is just like. Now you can see in this abnormal dilation of both lateral ventricles, and even the third ventricle is also dilated. This is also normal ventricles, the lateral, third and fourth versus abnormal, all are dilated, enlarged ventricles. Other coronary sections show normal ventricular size of lateral ventricles and huge dilated both lateral ventricles. Also, a cross section or axial section of the brain, normally sized lateral ventricles and abnormal enlarged lateral ventricles. Now, we said that we have two types of hydrocephalus, non-communicating and communicating. Non-communicating or obstructive. Now, we will divide the pathological causes of hydrocephalus into these, the radiological classification, so that we said that the obstruction till the fourth ventricle are called obstructive hydrocephalus. If the obstruction is distal or there is overproduction, it will be called as communicating. Now, what are the causes of non-communicating hydrocephalus or obstructive? First of all, lateral ventricular obstruction by a tumor, example, basal ganglia, glioma or thalamic glioma. Now, what we are going to suspect in this case, we are suspecting that if the tumor is unilateral, for example, thalamic glioma or basal ganglia, for example, in the right or left side, one side only, there will be dilatation of that ventricle and push to the other side. And for example, occlusion of the single foramen of Monro between the lateral and third ventricle, and cause dilatation of the above ventricle with pushing of the other ventricle to the other side. Now, we'll go slightly down. Now, if there's third ventricular obstruction due to cholecysis, for example, or third ventricle, or glioma of the third ventricle, in these cases, we will get occlusion of the third ventricle. Occlusion of the third ventricle, and you will see this clearly by CT scan or MRI. And this will result in dilatation of both upper lateral ventricles. Lateral ventricles mean both dilation. Now, what are you going to see in the CT scan of the brain? You will see that the lateral ventricles, right and left, both of them are dilated. The third ventricle will be seen as occupied by the tumor, and the fourth ventricle will be seen normal or smaller in size. Occlusion of the, now we go lower down between the third and fourth ventricle. Occlusion of the aqueduct of Sylvian or Sylvian aqueduct, either primary stenosis, which is the most common cause, or secondary to tumor. This will result in what is called the triventricular hydrocephalus with enlargement or dilatation of the both lateral ventricles and of the third ventricle, and there is no mass lesion, but you will see that the fourth ventricle will be normal or smaller in size. Fourth ventricular tumor or fourth ventricular obstruction, either due to posterior fossa tumor, posterior fossa tumor, all posterior fossa tumor will result in occlusion or pressure on the fourth ventricle. These posterior fossa tumors may be a tumor inside the fourth ventricle, for example, medulloblastoma or ependymoma, or a tumor outside the fourth ventricle, compressing on the fourth ventricle, for example, cerebellar tumor, glioma, or for example, acoustic neuroma. These are outside the fourth, tumors outside the fourth ventricle, but are compressing on the fourth ventricle, causing obstruction. Now, what will happen? There will be also triventricular hydrocephalus, dilation of the lateral ventricles and of the third ventricle. The difference between it and between this aqueduct stenosis, that in this case, the fourth one, you will see there is mass lesion either inside the fourth ventricle or outside of it, compressed on it. While in case of aqueduct stenosis, you will see no obstructing agent. All of these will result in what is called obstructive hydrocephalus because there is obstruction until, as I said, till the fourth ventricle. Now, The etiology of communicating hydrocephalus. Communicating hydrocephalus, there is failure, for example, failure of absorption of CSF through the arachnoid granulations. I mean, there will be, yes, there's obstruction, but where's this site of obstruction? So distal at the site of arachnoid villi, so that they will not be able to absorb CSF. For example, failure absorption of CSF through the arachnoid granulation over the cerebral hemisphere. For example, sclerosis or scarring of the arachnoid granulations can occur after meningitis, for example. You know, but this bacterial meningitis, bacterial or tuberculosis, will result in fibrosis or scarring of the arachnoid villi, and they will be not able to absorb CSF. Subarachnoid hemorrhage, also spontaneous or traumatic or postoperative, there will be blood clot occluding these arachnoid villi and preventing absorption of CSF, or after trauma, I mean traumatic injury to the arachnoid villi, and they will be unable to absorb CSF from its so that in this case, what are we going to see in CT or MRI? There will be dilatation, because CSF will be accumulated around these arachnoid villi. They are not unable to absorb, and we return back to the sentence which we said that CSF production is an active process independent of intracranial pressure. Now what will happen? CSF will be backward pressure to the fourth ventricle. It will be dilated to the third ventricle, will be dilated, and the lateral ventricles all will be dilated. This case you will see in the CT or MRI, dilation of all ventricles with no any mass lesion. In that case, you will say that this is complicated hydrocephalus due to either scarring of the post-meningitis, or subarachnoid hemorrhage, or due to trauma. The other case at which we are getting also communicating hydrocephalus is oversecretion of CSF. This is caused by a tumor of the choroid plexus called choroid plexus papilloma. This case, there will be overproduction. I mean, you know that normally production of CSF is 450 cc per day. Now, it will be if there is tumor of choroid plexus, the secretion will be more than 450. For example, 500 cc, then would be 600, 700, 800, 1000. The arachnoid villi will try to compensate. They are able to absorb 450 cc, just like the production. Now they will say, open the gates, please, and receive more than 450. They will receive, for example, 500, 600, 700. After that, they will not be able to compensate more and more. So the CSF will be back. And backward pressure, dilation of the fourth ventricle, third ventricle, and both lateral ventricles. And what are you going to see? Pan-ventricular hydrocephalus, just the same like the other case of post-meningitis, for example. Also, there is dilatation of all ventricles. But in CT scan, what we are going to see? We are going to see that there's dilatation of all ventricles, just the same, but there is mass lesion. You will see mass lesion inside the lateral ventricle, which is the site of a tumor called plexus papilloma. Now we finished two types of classifications. Radiological classification into communicating or obstructive, and then pathological classification according to the site of the region. All of them we mentioned to you, the causes. Now the last classification, which is the most important, clinical classification, is the clinical classification. I mean, how you can classify patients with hydrocephalus on bedside. I mean, when you are going, for example, to the hospital and seeing patients, you will say this patient is having this type or this other type. In fact, regarding the pathological classification, for example, choroid plexus papilloma or thalamic tumor or other types, or for communicated obstructive, you are unable to decide them on clinical ground. You are in need for definitely you are in need for radiological investigation to say what's this type. But here, this is the classification, clinical classification according to the hospital stay of when you are saying the patient, you are going to say this patient is having this type or the other type. With regard to the clinical classification of hydrocephalus, we are saying that we have two types of hydrocephalus. The first one is called neonatal or infantile hydrocephalus. The other type is the adult type. What is the difference between them? Now, I want you to imagine what is going on. First of all, there is obstruction of the CSF pathway or overproduction or any other pathology causing increase in the amount of CSF inside the ventricular system of the brain. This ventricle will be enlarging, and then it will compress on the brain tissue. The brain tissue will be compressed over the bone of skull from inside. It will compress over the bone. Now, the difference between neonate or infant and the adult is that in adults the skull is a closed box, while in infant this box is still opened by opened non-fused fontanelle, the fontanelle and the coronal suture and lambda sutures, so that what will happen? These bones will be pushed. For example, frontal bone will be pushed anteriorly, parietal laterally, occipital backward, and there will be huge enlargement of the head. So that this is the main difference between infantile or adult. In adult, no, there is no any dilatation of the brain of the skull, so that there will be just features of increasing the cranial pressure. You know them very well. So that what are the clinical features of patient having neonatal hydrocephalus? Number one, there is failure to thrive and feeding problems. The patient family will complain from this. There's enlargement of the head with increasing head circumference as measured on the percentile charts. Craniofacial disproportion, this is quite important, with expansion of the dome and lucid ears and lucid eyes. Now, what will happen in this case? In this case, the cranium and the face. What do you mean by the cranium is the upper, the vertex of the head, while the face, what you are going to see in the eyes and the other things. Now here, the dilatation of the head or enlargement of the head will be just involving the cranium. I mean the vertex of the head, while the face is still same size. So that there will be this proportion between the size of the cranium and the face. And I'll mention to you this in detail after a while. The skull is thin and glistening. Why? Because it's stretched. Just the same as seen in ascites. When ascites distend the abdomen, you will see this, the skin of the abdomen will be thin and glistening. Here also the scalp will be thin and glistening. The veins of the scalp are distended, the same as seen in ascites as well. The anterior fontanelle is enlarged, tense, and bulging. You can feel the anterior fontanelle is enlarged and tense and bulging. Weakness of upward gaze. What will happen that what's called the setting sun sign or sunset eyes. This is due to interventricular pressure on the midbrain tectum responsible for upward gaze. Diastasis of the cranial sutures, I mean separation of the cranial sutures, you know that they are not fused, but they are one beside the other normally. In this case, no, they will be separated, there will be gap between them as if there's a fracture. A transillumination of the head is usually positive, but this is to be done, should be done in patient under 9 months of age, because after that 9 months of age, the bone will be thick and definitely this test will be negative. You must also put the patient in dark room. What is the aim of this transillumination test? I will get from it that if it is positive, I mean less than 9 months baby, and it will not help me in the diagnosis of hydrocephalus because I know the diagnosis of hydrocephalus from the other mentioned above features. But what will be the aim of this transillumination? First of all, the patient must be less than 9 months of age, and then I do the test in dark room. If the test is positive, this means that the cortical mantle, I mean cortical thickness of the brain, is less than 1 cm. So that this means that there's a severely atrophied brain tissue. While if the cortical mantle is more than 1 cm, the test will be negative. So that if the test is negative, it's better than to be positive. Lastly, bradycardia can be seen in extreme cases, and you know this is sign of increased cranial pressure, which I mentioned in the last lecture. Now, in this image, you can see very well the enlargement of the head is quite clear. The even some veins, I'll show you a clearer picture later on. Now you can see the sunset eyes or setting sun sign. Now, what do we mean by the craniofacial disproportion? If I take a measure from the vertex of the head of any person from this vertex, top of the head, to the chin, then I divide this from here to here, then this is the vertical, then I'll take this uh, midline. I'll try to show it by this measure. In fact, if I do a measure at here, okay, the other one is at here, then we will join them. Then I will try to transect this into half. The half will be like this. Now, what are you going to see? This is this one equal to this one. low set ears and low set eyes are quite clear in this image. Okay, so this is what we call as a craniofacial disproportion. Okay, next. Other image you can see in this one also enlargement of the head, craniofacial proportion, low set ears and low set eyes, and sunset eyes, also glistening and shiny scalp and dilated veins. These are quite clear features of hydrocephalus. Other one also enlargement of the head, number one, and low set craniofacial proportion with low set ears and low set eyes, sunset eyes, a glistening scalp and dilated veins, very clear, and also transformation is positive, indicating that the cortical thickness is less than 1 cm. Also, other picture showing to you the last infantile hydrocephalus with quite clear, even dilated veins are to be seen very clear. Now, this is an old picture because I put it here to show you that this disease is an old disease, not a new disease. While in cases of adult hydrocephalus in all children and adults, these are only features of increased intracranial pressure, headache, and I will not repeat the details of this headache, morning headache, and etc. Nausea and vomiting, deterioration level of consciousness, may be associated with ataxia or visual disturbances. All these are features of increased intracranial pressure. What are the investigations to be done for patients having hydrocephalus? In fact, we have the following investigations, which I just mentioned all these routine investigations to you in the first lecture. This is like X-ray, ultrasound of the brain, CT scan of the brain, MRI of the brain, and lumbar puncture. I will discuss what do you mean by lumbar puncture in case of hydrocephalus. Now, in skull X-ray, I'll see, in fact, I'll tell you something that this investigation, not all of them are done usually, but we must mention what are the normal findings to be seen in these investigations, so that in skull X-ray, it can show to me separation of the sutures. I mean, for example, coronal suture is separated, or lambda suture is separated, or superstitious suture is separated from each other due to increased cranial pressure and pushing, or physio, or can see physio of increased cranial pressure, and these are to be seen in adult type hydrocephalus after chronic pressure on the head from inside. For example, in this one, you can see separation of the superficial suture, and these are separated very well clear. The lambdoid suture is separated. In fact, this patient is also having separation of coronal suture, but not clear in this AP image. Okay. While this is the picture which you will see in case of increased temperature in adult. What we call the cover beating and marking of the skull. I just mentioned this to you in the last lecture. Other investigation for hydrocephalus is ultrasound of the brain, and this should be done through the anterior open anterior fontanelle. And I mean it is to be done only for infants, because adult we are unable to do this because there is a closed skull. Now it can be done through the open anterior fontanelle to see what will the ventricular system. In fact, the ultrasound will give me the following information. It will give me information about the size of the size of the ventricles, the lateral, third, and fourth ventricle, whether normal or abnormal, enlarged. Also, can tell me about the cortical thickness of the brain tissue, and lastly, it will give me information about any specified region or blood inside the ventricle or inside the brain. Also can be given from this ultrasound. It is simple and invasive and can be repeated many times for the patient. You can see in this ultrasound dilatation of lateral ventricles, very quite clear. Other investigations, CT scan and MRI of the brain, in fact, they will show to me the ventricular dilatation and they can show the cause of obstruction, for example, as tumor or other things. MRI also same as CT, but with no radiation, so can be used for a follow-up and to be repeated more than one time. So that in this case, the final diagnosis will be by CT or MRI of the brain, which will show to me not only dilatation of the ventricle, but can show me also the cause of hydrocephalus. Now, in these films, from down upward, and 1, 2, 3, 4, and also 5, 6, 7, 8. All these 8 slides are of the same patient. What are we seeing? I'll go from up down. You can see dilatation of both lateral ventricles. Both lateral ventricles are dilated as well. The fourth ventricle is also enlarged. The third ventricle, sorry, also enlarged. Third ventricle. and go back. Now the third ventricle enlarged. These are the lateral ventricles and the lateral third ventricle, and also the fourth ventricle is hugely enlarged. So that this, in this case, there's dilatation of all ventricles, lateral, third, and fourth, panhydrocephalus. Did we see any lesion? I mean, any specific lesion? We said no, no any lesion. So that this is a type of communicating hydrocephalus. What are the possible causes for this communicating hydrocephalus? Maybe, as I mentioned, scarring of the arachnoid post meningitis or post traumatic or post subarachnoid hemorrhage. In this other image now, there is dilatation of the lateral ventricles, but now you can see there is a mass. What is this mass? This is choroidal plexus papilloma, tumor of the choroidal plexus. In this case, you will see that dilatation of lateral ventricles. And if you go down, you will see dilatation of the third ventricle and of the fourth ventricle, as you just see in the previous sections. Okay, but what is the difference between this and this one? That in both of them are communicating hydrocephalus. The separation between communicating and obstructive will be lying on the fourth ventricle. If it is dilated and all the above are dilated, this is communicating. If any obstruction at any site is obstructive, so that as far as the dilatation, they will be called as communicating. This, in this case, you will see also the third ventricle dilated and the fourth will be also dilated. But the difference that in the previous slides we saw no mass, while here clear mass. So this is communicating hydrocephalus due to choroidal plexus papilloma, a tumor secreting excessive amount of CSF. Now we will go to lower down by obstruction at different sites. For example, this is left-sided thalamic glioma. Okay, you see that this resulted in obstruction of the flow of CSF from the lateral ventricle to the third ventricle, unilateral hydrocephalus. Even the other one is also getting enlargement. This case, other case, by this is a coronary section, this axial section of other patient, but this patient is having right side. That's what left side is right sided thalamic glioma. You can see dilatation of the lateral ventricles higher up. Now, lower down, we are going to the third ventricle. Now, the third ventricle occluded totally by this tumor. The scoliosis of the third ventricle results in dilatation of both lateral ventricles. The third ventricle will be occupied by the tumor. The fourth ventricle, lower down, we suspect it to be smaller or normal size. Then, going lower down between the third and fourth, we have this case. For example, in this case, what are we going to see? We are seeing the lateral ventricle is dilated, the lateral dilated. The third is also dilated, while the fourth is of normal size or even smaller than normal size. This means that obstruction between the fourth and the third. This is a typical case of aqueduct stenosis. Then, going more lower down, you can see this is a posterior fossa tumor. There is a tumor occluding the fourth ventricle and resulting in dilatation of the third ventricle and of the lateral ventricle. So this is the other last case of obstructive hydrocephalus due to posterior fossa tumor. Now, how to be appear on MRI? This is T1 and this is T2. You can see also dilatation of ventricle in axial view and in the sagittal and coronal view of MRI. Last investigation, lumbar puncture. In fact, lumbar puncture, if there is obstructive hydrocephalus due to tumor, it's contraindicated, but it can be done in only communicating hydrocephalus, even if the patient is having papilledema. There is no contraindication because there is no specific lesion. We have no fear from any herniation of the brain. For both diagnostic done and therapeutic aims, I mean, the diagnostic to measure the pressure of the intracranial pressure, and therapeutic to get rid of excessive amount CSF until we would do a final surgery for the patient. How to manage hydrocephalus? Management will be either medical or surgical management. The medical management of hydrocephalus by using method to reduce CSF production, and in fact, till now, no different medical treatment is satisfactory. So that if I ask you, is there any medical treatment for hydrocephalus? Say there is no medical treatment for hydrocephalus, and all hydrocephalus are treated by surgery. Surgical treatment of hydrocephalus by removal of obstructing agent, like removal of a tumor. With this, we resolve hydrocephalus. I mean the obstructing agent. But put in your mind that this is not always possible to start with. Because if I do, for example, posterior fossa tumor, if I do removal of it with the presence of hydrocephalus, what will happen? I open the skin of the back of the, then opening the bone, then open the dura. Once I open the dura, all the brain will be herniated through the wound, and the patient will die on the table. So that we, first of all, we do something for this patient, or I mean, let the CSF be out and or be able to go to the other side, and then do excision of a tumor. The other method to treat hydrocephalus is by bypassing obstruction, either by the following method: endoscopic ventriculostomy. Here we will create opening. For example, a patient having aqueous stenosis, there will be dilatation of the third ventricle and of both lateral ventricles through an opening just in the front of the head, anterior to the coronary structure. I'll do burr hole, and then I'll introduce the endoscope. It will enter first of all to the lateral ventricle, and then it will go to the third ventricle, and then in the floor of the lateral ventricle, third ventricle, I'll do an opening. This opening will lead the CSF to the other CSF side called pre-pontine cistern. These are areas or just like lakes of CSF. They are not ventricles. Okay, this will bypass the obstruction, and in fact, this is not to be done always. It can be done only after 6 months of age, and non-communicating hydrocephalus must be obstructive hydrocephalus. If a patient, for example, aged 1 month and having hydrocephalus, this is not a good option for him to do endoscope. So we will do the other options. I mean, transdermal shunting. External drainage of CSF by ventriculostomy to the outside, helpful in temporary management of acute hydrocephalus, and this of infection recruit long treatment because it is connected to the outside, so it is just temporary measure to treat hydrocephalus. The last one is internal diversion by shunting. These are the shunting. This is the most common form of surgical management, and the most common shunt used are ventriculoperitoneal shunt or ventriculoatrial shunt. By ventriculoperitoneal shunt, I will combine the ventricles to the peritoneal cavity, or atrial shunt to the ventricle to the right atrium, or pleural shunt to the pleural cavity. Now, I'll go back slightly. This is how we do the endoscopic third ventriculostomy. Now we introduce the endoscope to the third lateral ventricle, then to the third ventricle, and do this opening. It will take CSF to the pre-pontine cistern. You can see the image at endoscopy just like this. I will do opening. These are common mammillary bodies. I'll do opening at here, which will open just inferior to the pre-pontine cistern. Now, the types of shunts, as I mentioned to you, are ventriculoperitoneal shunt, a ventriculoatrial shunt, or ventriculopleural shunt. This will connect the lateral ventricle to the lateral ventricle of the peritoneal cavity, or to the atrial shunt, I mean to the right atrium, or to the pleural cavity. The most common, in fact, used, you can see this one, the ventriculoperitoneal shunt, is the most commonly used shunt. Why? Because its complications are less dangerous than the complications seen in ventriculopleural or ventriculoatrial shunt. Now, what are the complications of shunt surgery? In fact, I show this. This is the CT scan of her brain showing shunted both lateral ventricles. You can see that all shunt parts are radio opaque, and inshallah, in the 6th stage, I'll give you clinical session about hydrocephalus and its management. The complication of shunting, shunt obstruction, these are for all types of shunts. Shunt obstruction, either at the upper end or at the lower end of the shunt infection by any microorganism, and lastly, intracranial hemorrhage. Intracranial hemorrhage either due to intracerebral hemorrhage, I mean, we may hit an artery cortical vessel during installation of the upper end, or subdural hematoma. Subdural hematoma will happen if I do shunting to the patient with the pressure gradient less than that needed to the patient. For example, if the patient have high pressure hydrocephalus, need high pressure shunt, or low pressure need low pressure shunt. If a patient having high pressure shunt, high pressure for hydrocephalus, and I put for him low pressure shunt, there will be over range of CSF and result in rapid shrinkage of the brain tissue, result in tearing of the bridging vessels from the cortex to the venous sinus, and resulting in subdural hematoma. These are the complications mainly seen in all shunts, and mainly in ventriculoperitoneal shunt. Regarding complication of ventriculoatrial shunt, in fact, I said in addition to the previous three, there will be also other dangerous complications like infective endocarditis, volume overload, because the CSF will overload the heart because it will be added to the blood and result in heart failure, or maybe arrhythmia, because you know that in the wall of the lateral vent, in the wall of the between the dual atrium, there is the SA node. and this will may be irritated by the lower end of the catheter of the shunt and may result in arrhythmia. So that you see that these are dangerous complications. Complications of ventricular pleural shunt, pneumothorax and hemothorax during installation of the shunt. A pleural effusion due to excessive amount of CSF will be mixed with the pleural fluid or got infection of this fluid. Now you see that the complications of ventriculoperitoneal, ventricular atrial, and ventricular pleural shunt are very dangerous, much more dangerous than complications of the ventriculoperitoneal shunts, so that we put them always as a second choice after the failure of the ventriculoperitoneal shunt. Now I go to the second subject, which is correlated with this subject, which is developmental congenital anomalies of the spine. You would say, what is the relationship between the spina bifida or spine dysraphism and the disease of spine with hydrocephalus? I'll tell you later on. Now, what do I mean by anomaly? This anomaly of spina bifida. You know that the spinal cord is located inside the vertebral canal, which is formed by many vertebrae from down upward. Everyone is having vertebral canal, and from this all we will get a cylinder or tube. This tube will containing the spinal cord, and from between each vertebra and the other, we have exit of nerve root. Now, normally this tube is closed from up down. In this case of spinal bifida, there is opening in the back of the spine process. This will lead, because you know that all the brain tissue, all the brain at central level, the brain and spinal cord, inside the dural cavity of the spinal cord and of the brain, all are tense under intracranial pressure, so that there will be a gradual pushing of the structures at this side of bifida to the outside and may result in anomalies. Now, by definition, spinal bifida, this is the most common developmental anomaly affecting the spinal column, and it means failure of the neural tube to close fully. So there is split or open spine. The deformity will appear at this site. This is the body of the vertebra. These are the pedicles and the transverse process. They are pedicles and lamina, and this is last the spinous process. In fact, defect will be at here, not at here, not at here. Okay, this is the vertebral canal. Spina bifida is of different types, either spina bifida occulta or cystica or aperta. From its name occulta, I mean يعني مختفي ما موجودة يعني ما تبين. Cystica from cyst. Aperta very apparent. Now, this is normal spine, vertebral body, transverse process, pedicles, and spine lamina and the spinous process. And this is the vertebral canal containing the spinal cord. Spina bifida occulta. The posterior vertebral arch has a defect within it, but there is no herniation of the neural tube. I mean, nothing will be outside. The defect is found in 10% of the population. This is not a small number, which means that for every 10 people you see in the street, one of them is having this defect, but he may not know about it. On the skin over the defect, various skin changes may be seen, like hairy patch or area pigmentation, fatty lump like lipoma, or sometimes dermastanus can be seen. By seeing this, you will say that this patient is having a spina bifida. If you do for him skull X-ray of the spine, you will see that defect, which will be apparent. This is the site of the defect. You can see that it's a small defect, not large defect, and the spinal cord is placed. Nothing is going outside. Okay. This is the vertebral bodies, and these are the spinous processes. You can see defect at here, but this is the spinal cord, and this is the dural sac. You see that this dural sac is not going outside through this defect, but there's a hair patch at here. What are the abnormal things to be seen on the back of this patient? For example, this is abnormal hair patch at this side, lower back. This may indicate to me that this patient is having spina bifida occulta. Or abnormal pigmentation at this site also may mark me that this patient is having spina bifida occulta. This is lipoma. This is swelling lipoma. In addition to also to this abnormal hair. This lipoma may lead me to the diagnosis of spina bifida occulta. Or this is dermal sinus lower down in the back may also lead to diagnosis of spina bifida occulta. Now, in spina bifida cystica, in this situation, there is no covering. There is the skin covering the defect, making a cyst-like. If this cyst contains CSF only, I mean covered by meninges, it is called meningocele. If there is neural tissue within this tract, it is called as myelomeningocele. Now, you can see this defect is bigger than the previous one. The spinal cord is still in its place. Okay. Now, this is the vertebral body, the spinal cord, the black color, and this is the dural sac. If the dural sac, is going outside alone, this contains only CSF, the spinal cord not moving, this is meningocele. While in this case now, something moving outside, the spinal cord moved outside, and this is called meningomyelocele. You can see that vertebral body, this spinal cord is going outside and inside this cyst. So this contains CSF and the spinal cord. Is a case of meningomyelocele or myelomeningocele, the same term as it say myelomeningocele or meningomyelocele. Okay. The last one is spina bifida aperta. Spina bifida aperta, the neural tube is opened with no skin coverage. Through the defect in the posterior vertebral arch, no skin coverage, the CSF leak usually occur. So there is a high risk of meningitis. In fact, these cases are not compatible with life. You can see, for example, this image. This one, the skin is open, the dura is open. You can see this is spinal cord. While this is much more clear, very clear that everything is open. It's not compatible with life. This is spina bifida aperta. What about the etiology of spina bifida in general? 90% of the cases occur sporadically, no definite cause. Hereditary factors sometimes play a role. Children of parents with spina bifida have a 5% risk of having the condition. Dietary factors, they found that folic acid administration during pregnancy may lower its incidence. Also, some anticoagulants medications can result in the patient having, if the mother is taking anticoagulants, anticonvulsant may got a baby having also meningocele or meningomyelocele, spina bifida. In fact, most of these are not definite, just theories. And we found patients who are having no hereditary factor, and they are the women, the mothers were taking the folic acid, no anticonvulsant were used, and they got spina bifida. So that they are not so definite, but we sometimes blamed as a cause for spina bifida. Regarding clinical features of spina bifida, we will speak about them into 5 stages, either antenatal or post-delivery. General features, then speak about bifida occulta, meningocele, or meningomyelocele. Regarding antenatal screening, by using detection of alpha-fetoprotein in the blood is in the amniotic fluid obtained by amniocentesis, this will give me a clue about the presence of spina bifida. The use of ultrasound, in fact, ultrasound of the uterus of the mother will show to me the presence of this cyst. Both tests allow detection of such defect in over 80% of embryos with open neural defect. This is how to get the blood from amniocentesis to take this amniotic fluid, search for alpha-fetoprotein, maybe through vagina or through the abdomen. In fact, what we will do for them, we will do nothing. Post-delivery, general features include the incidence of ranging from 1 to 8 per 1,000 of population. It is not a small number. Most problems tend to occur in the lumbosacral area and are associated with changes in the bladder and bowel function. For example, incontinence of urine. The higher the lesion, the more severe the defect. What we mean by this? You can imagine the spinal cord going from up downward, just like the generator. شلون الكابل مال المواليد يطلع يوزع الى البيوت، كل ما يطلع يوزع يمين يسار يمين يسار راح يرفع الكابل ينتهي في بيتين. خلينا نقول اذا اجى مثلا خلينا نقول فرد لوري ضرب الكابل في وسطه، هذا مال 100 بيت، ال 50 بيت بعد امام الضربه اللي قدام راح يكونون no electricity with them, while before between the generator and these homes they will have electricity. هون يكون كل ما نقترب احنا من يكون ضربه تكون اقرب على المولده، خلينا نقول كل ما يكون الديفكت راح يكون اكثر، ضرر اكثر البيوت. فهون نقول انه the higher the lesion the more severe the defect, the deficit. If the lesion is open, then the associated risk of meningitis. Other associated disorders include ulnar carry malformation. What do we mean by this? Ulnar carry malformation type 2 and in up to 80% hydrocephalus. Now I am going to the important thing, the correlation between the two subjects. Hydrocephalus with spina bifida. Over 80% of patients having meningomyelocele mainly, they will have hydrocephalus. And why they got hydrocephalus? In order to understand why they got hydrocephalus, I return back with the previous slides. Let me go back. 1, 2, 3, 4, 5. Now, okay. You can see this one. In this case, for example, this is meningocele. You see that this is containing only CSF. Now, this is not important for me. What's important for me is the state of spinal cord. It is just located at its place. Okay. Now, when we go to the meningomyelocele, what do you see? The spinal cord is outside. Why? It is going outside. What will happen there then? They are pulling of the spinal cord downward to go inside the cyst. What will happen higher up? There will be herniation of part of the cerebellum through the foramen. As we mentioned in the last lecture of intracerebral pressure, the type of herniation is called tonsillar herniation. Tonsillar herniation of many grades, for example, grade 1 or grade 2. Or grade 3. Grade 2 will happen in infants and diagnosed early because they will got hydrocephalus. So that 80%, when we said 80% is not a small number. When we said 80%, I mean from each 100 patient having meningomyelocele, 80 of them are having hydrocephalus. From each 10, 8, and from each 5 having meningomyelocele, will got all 4 of them will got hydrocephalus, which is not a small number. So there's great association between hydrocephalus and meningomyelocele. You can see, for example, in this case, this is a case of meningomyelocele mostly with hydrocephalus enlargement of the head. Spina bifida occulta, I showed you the pictures of it, usually asymptomatic, accidental finding on X-ray or by examination, lipoma, skin dimple, tuft of hair over the bifid spine or abdominal pigmentation. Rarely urinary incontinence starting at adolescent can also be seen. Meningocele hair, no neurological manifestations, cystic translucent swelling within expansible impulse on cuffing. The swelling is compressible. I mean, if you compress it to disappear, then it will be coming outside. While this case, for example, picture showing to you meningocele. How I know this meningocele? Because it's covered by normal skin. If it is covered by normal skin, this is definitely meningocele. If it's covered by abnormal skin, maybe meningocele or meningomyelocele. But let's have you see, as you see, this normal skin, this is meningocele. This is also meningocele, and meningocele. Myelomeningocele, here the patient will got paraplegia. Why? Because there is the spinal cord is outside the spinal canal, inside the cyst. I mean the meningomyelocele. During pregnancy and during moving into intrauterine life, there will be hitting of the wall of the cyst and the contents. I mean spinal cord with the wall of the uterus, and even at delivery, there will be injury, total injury to the spinal cord, result in paraplegia. So this paraplegia vary, maybe complete paraplegia or maybe just paraparesis. Wasting or contractures with sensory loss, all will be happen. Trophic disturbances are marked, especially perforating ulcers of the foot. Other congenital anomalies associated mainly hydrocephalus. As we said, 80% of these patients got hydrocephalus as well. It's a case of meningomyelocele, and this is also the features you can see meningomyelocele. Other anomalies for like left foot, ulcer, incontinence, urine, and feces. You know the principle that once you see a patient having one congenital anomaly in the body, search for others may see other anomalies as well in the patient. So that this patient having meningomyelocele also having club foot. This is a case of meningomyelocele. In fact, to be definite, this is also having hydrocephalus. To be different diagnosis of meningomyelocele, you must examine first of all the lower limbs, because sometimes we saw patients having abnormal covers of the skin. We told you that if this normal skin, this is definitely meningocele, only CSF. But we found patients having this abnormal skin, but they are moving their lower limbs very well and controlling the sphincters. So that don't say this meningocele unless you examine both lower limbs for movement, and then if they are moving there, you will say this is meningocele. But if they are not moving, you will say this is meningomyelocele. What investigations you will send or do for the patient? First of all, I must do head circumference measurement to check for associated hydrocephalus. This is will make the patient family feel surprised. I told because they brought the baby to me, for example. What's this problem? This problem is opening in the back or cyst in the back. They'll be surprised when I'm going to examine the head to measure the OFC of the patient or diameter. Why he's measuring the circumference? because they don't know the association of hydrocephalus with this case. A parallel graph of the spine, you see the spina bifida. In fact, we don't do this, but I just mentioned to you. Ultrasound of the brain to exclude hydrocephalus. Lastly, CT or MRI of the brain, also to rule out to exclude hydrocephalus if it is present. Now, what about the treatment of spina bifida? To start with, spina bifida occulta require no treatment in the majority of cases. In other forms of open spina bifida, surgery should be performed as early as possible, include closure of the defect, for example, as possible to avoid meningitis, mainly in case of meningomyelocele or ruptured meningomyelocele or meningocele. In fact, you must tell the family the following important thing: uh, that if the patient is paraplegia, having paraplegia, tell the family that after closure of this cyst and repair of the defect, he will not get a returning of his movement of the lower limbs. You must put this for medical legal importance. Also, hydrocephalus need immediate shunting even prior to closure of the defect of spina bifida. Priority for hydrocephalus. From this point, we will get, and from the last point mentioned to you in the management of hydrocephalus, we said removal of the causative agent like tumor. We said that first of all we do shunting and then we will do excision of a tumor. Here we will do shunting first of all and then closure of the defect. Why? Once you remember in your memory this sentence: if a patient is having hydrocephalus plus other pathology, priority is for hydrocephalus, whatever the cause. Now, hydrocephalus due to tumor, postoperative tumor, what is the aim of shunting before surgery, before excision of a tumor? Because if I do a trial to excise the tumor without shunting, there will be herniation of the brain, the patient will die on the table. While in case of meningomyelocele, if why hydrocephalus a priority over meningomyelocele? Because delaying in shunting will result in more and more enlargement of the ventricle and more compression of the brain cortex and result in more brain atrophy to the patient. So that this is not to be forgotten. And lastly, I repeat this one, which is quite important, that for your safety, please tell the family about this fact before doing surgery for this patient who are paraplegic, that the aim of surgery is just closure of the defect for cosmetic purpose, number one, and to avoid meningitis if it is injured, I mean the system to be injured, and not the aim of surgery is the turn back of movement of the lower limbs or controlling of sphincters. And this is irreversible. Okay. Thank you very much for your listening. I hope it's not to be so long for you, and I'm ready to receive from you any question if it is not understandable to you. Thank you very much, and see you later on, inshallah, in other lecture, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.